My name is Naval. I am a leukemia physician at the MD Anderson Cancer Center in Houston, Texas. Today I will be talking about Gemtuzumab Ozogamicin or Mylotarg, a monoclonal antibody conjugated to CD33 with calicheamicin, a bacterial toxin. Mylotarg was initially granted FDA approval in the year 2000 based on a response rate of 30 to 35% seen in patients with relapsed acute myeloid leukemia treated with this agent. One of the concerns that emerged in these initial trials was a high incidence of VOD in the range of 3 to 6%. It is possible that the VOD that we were seeing in these initial trials may have been associated with the higher dose of Mylotarg, which was 9 milligrams per meter square used every 2 weeks, as with the lower doses of Mylotarg, the incidence of VOD seems to be much lower in the recently concluded trials. After the initial approval of Mylotarg, the drug was evaluated in a confirmatory phase 3 double-blinded randomized control trial of induction chemotherapy with cytarabine and daunorubicin versus induction of cytarabine daunorubicin with Mylotarg in newly diagnosed younger patients with acute myeloid leukemia who were candidates for induction therapy. This study unfortunately did not show any improvement in survival with the addition of Mylotarg, and in fact there was an increased incidence of early mortality defined by 4-week and 8-week mortality in the patients who received Mylotarg. The concern was that the Mylotarg was causing increased toxicity, and based on this, Pfizer voluntarily withdrew the drug from the United States market in 2004. Subsequently, the agent has been evaluated in multiple large phase 3 studies done in multiple countries in Europe. A recent meta-analysis published by Dr. Hills in Lancet Oncology shows that in a total of 3,000 plus patients evaluated in 5 randomized trials, Mylotarg was shown to be effective when given in combination with induction chemotherapy. There was a survival benefit that was most clear in patients with favorable cytogenetics defined by core binding factor cytogenetics such as inversion 16 translocation 821, and also a survival benefit seen in patients with intermediate cytogenetics. However, the benefit was more clear in the patients with the core binding factor leukemia. This was the design of the Alpha 0701 study, which was one of the central studies that was evaluated by the United States FDA when they reapproved Mylotarg in July of 2017. This study is again a phase 3 double-blinded randomized open-label study for newly diagnosed younger patients with untreated AML. Patients in this study were between the age of 50 to 70 years of age, and they were randomized to receive induction therapy with daunorubicin and cytarabine alone, or daunorubicin cytarabine with Mylotarg. Note that in this study, the dose of Mylotarg that was used was a lower dose than the previous United States-based studies, with the dose of 3 milligrams per meter square given on day 1, 4, and 7 during induction in combination with chemo, followed by only 1 dose of Mylotarg at the lower dose of 3 milligrams per meter square given on day 1 of consolidation number 1 and 2. The primary endpoint that was defined for this study was event-free survival, and as you can see, there was a clear benefit with the addition of Mylotarg, and at 2 years, the event-free survival was met in 42% of the patients who received Mylotarg with induction chemo, as opposed to only 18% who received induction chemotherapy alone, resulting in a very significant p-value. The FDA saw this study as a favorable study, and this study, in addition to 2 other studies, one of which is the AML 19 study and the other was the Mylo-France study, led to the reapproval of Mylotarg for the United States market by the FDA in July 2017. So at this time, the approval label for Mylotarg says that it is approved for adults with newly diagnosed CD33 positive acute myeloid leukemia. This is based on the results of the Alpha 0701 study, where Mylotarg would be given in combination with standard induction chemotherapy. But note, it should be given at the lower doses of 3 milligrams per meter square, either on day 1, 4, and 7 during induction, or we would suggest even only on day 1 during induction, and then once with each subsequent consolidation. Mylotarg was also approved for any salvage in AML to be used as a single agent, And again here we would recommend a lower dose of Mylotarg of 3 milligrams per meter square to be used either on day 1 and 4 or day 1 alone and repeated every 2 weeks. So at MD Anderson, we are basically using Mylotarg in combination with induction chemotherapy for patients who have favorable or intermediate cytogenetics. This agent did not show benefit in patients with adverse cytogenetics, and we would not use it in this condition. In salvage settings, we would use Mylotarg as a single agent in patients who are not candidates for clinical trials. Thank you very much.